Discover the latest health tips, expert advice, and inspiring stories. This is the Health Channel Podcast. Your journey to better health starts now.
Did you know that heart disease is the #1 killer of most American men and women? It's important for you to know the warning signs. And on today's show, we will be joined by the Chief of Cardiology at Baptist Health's Miami Cardiac and Vascular Institute to answer your questions and offer you tips on how to help you prevent and treat heart disease. That's all coming up on an episode of Ask the Doc, No Appointments Needed. Hello and welcome to Ask the Doc, No Appointments Needed, the show where the health questions you send are answered by doctors and medical experts. Thank you for joining us today. I'm Kathy Buccio, and I am very pleased to be joined by Dr. Jonathan Fialkow, Chief of Cardiology at Baptist Health, Miami Cardiac and Vascular Institute. Dr. Fialkow, thanks so much for your time today, and so glad to have you join us again here on the Health Channel.
My pleasure, Kathy.
Amazing. Well, usually we begin with our questions, Doc, from the audience, but I like to spend a few minutes actually with you discussing prevention. So my first question is, what is the Miami Cardiac and Vascular Institute and Prevention Clinic, and how does it work?
Yeah, it's a great question. I mean, prevention is a term that we throw around quite a bit, and sometimes we don't truly define what it means. And the way I approach it, both with my practice and with what I lead, it starts with what do we want to prevent? And ultimately, we want to prevent death. That's the goal. Quite frankly, we're not going to. We're going to eventually succumb, but let it be under our own terms after a long, fruitful life. The most common preventable cause of death are cardiovascular. So if we want to ultimately prevent a premature death, we want to pay attention to the cardiovascular risks because those are the most common preventable cause of death. We can't prevent a lot of cancers. We can find them early, but we truly can prevent cardiovascular death. So when we're looking at preventing heart attacks, strokes, heart failure, those big drivers of that premature death and disability, the idea is the earlier we can recognize someone's at risk, the earlier we can assess the risk, and most importantly, the earlier we can lower the risk, the best impact we'll have in the people living a long and fruitful life, avoiding those cardiovascular consequences.
So obviously it's better to prevent a heart attack or a stroke rather than react afterwards, but can you do that? Can you actually prevent it before? Because I've heard in many cases a heart attack is the first sign of a heart disease.
So it's true, because people can live an asymptomatic life with a lot of the underlying components of what can lead to a heart attack. Sometimes the first symptom is a heart attack or even, unfortunately, a cardiac death, which is quite frequent. So the idea of a prevention center is both to educate the community, educate other doctors, and be the resource for people who have either consider themselves to have a high risk or consider to have a high risk towards assessing them. If that risk of a cardiovascular event, heart attack, is high, then how can we individualize the recommendations and treatments to avoid it? So we can avoid the heart attacks. The heart attack, the stroke, is the final result of many years of abnormalities in our arteries. So if we can identify who has the early stages of the abnormalities in the arteries or even prevent that, then we can avoid that late stage component, which is the heart attack. But as you mentioned, people can feel well, and that first symptom could be death and or a heart attack.
So this preventive approach can really yield those benefits and help down the line.
I'll add also that, the way we approach preventive care, it's not just the heart attack, because if you look at what's getting a lot of interest right now, though we've known for decades, a lot of the underlying inflammation in our body leads to these chronic diseases. And the chronic diseases, we could talk about cholesterol abnormalities, diabetes or prediabetes, obesity, sleep apnea, hypertension. What do they lead to? Well, increased cancer risks, increased heart attack and cardiac risks, increased dementia, increased renal failure. So the string theory, the underlying goal is who has those early risk factors, who has early disease, identify it and stabilize it and prevent it from getting to those other components. So surely we can prevent heart attacks and strokes by identifying who's at risk, and if that risk is elevated, lowering the risk. Unfortunately, too many people go through their lives and they're not having that risk identified, whether it's they're not paying attention or the medical community isn't accessible to them. And that's the community we want to both address and give opportunities to help avoid those cardiac events.
When you talk about risk, Dr. Fialkow, one thing that I find intriguing is that we're seeing a rise in cardiac cardiac issues being identified in those in their 20s and 30s.
Sure.
Why are we seeing this rise? We're also seeing it as well with cancer diagnosis. So what has changed or what has shifted?
A great question. And before I actually answer it specifically, I want to define something. When we talk about risk, risk is a probability, right? Risk is not an absolute. And what we should do as physicians, and what we should do and work with people, is you assess the probability. Nothing's an absolute. I have smokers who live to 100. I have people who run marathons and they have heart attacks. So you want to assess your risk, the probability, risk high, you want to lower it. So you don't want to make decisions and absolutes. Right. You're going to have this, you're going to have this, et cetera. Now, why I say that is when we look at the underlying changes in our lifestyle, changes in our demographics, right? We're a heavier population than we were in the past. We have more inflammatory components in our lifestyle where there's processed, ultra-processed foods, not natural. We don't get enough sleep. We don't get enough exercise. There are pollutants in the air, which can contribute to cardiovascular risks. We have other things that we're talking about, microplastics and various other exposures. So starting at a young age, when we're less healthy, I grew up on Captain Crunch and Yoo-Hoo. My grandparents grew up on natural foods from the market or from the farms and whatnot. So as we're exposed to more and more of these less natural products, and as our lifestyle has moved to one of more sedentary, higher stress, less sleep, we're seeing the younger population starts that inflammation earlier. So frankly, we're seeing these younger people with those inflammatory disorders, cancers and cardiac events, because our lifestyle has developed into one that is much less healthier than it was 50 years ago, no less, 25 years ago.
Right, and we're going to jump into that stress later, but I want to start getting into these questions, Dr. Fialkow, from our audience.
Sure.
And the first one comes from Angie, and Angie wants to know, heart disease runs in my family with my dad and my aunt. His sister dying in their early 50s from heart attacks. My brother and I are getting close to 50 and we're freaking out. We don't have a cardiologist yet, but we both have primary care doctors that we see on a yearly basis. What can we do to prevent history from repeating itself?
Yeah, it's a great question, Angie, and kind of the genesis of true prevention therapy. And I'm going to answer it by saying there's two things you can do. The first one is lead a healthy lifestyle, right? So not necessarily predicated on the medical community, understanding the benefits of staying active and exercising, understanding the benefits of eating food in its most natural form, avoiding processed foods, unnatural products that our bodies have never been exposed to in thousands of generations of evolution, getting a good night's sleep. And there are tips and habits to make sure your sleep habits are okay. So obviously lifestyle becomes critically important. Don't smoke becomes critically important. That you can do, and you don't need doctors to guide you to that. Maybe just a little bit better understanding, get a little more attention to that. From the medical standpoint, certainly when you're getting at the age of 50, you should have assessments regarding what is my cardiac risk. That could be through blood tests, certain markers, which can suggest either early disease or risk for disease, a good history. What are you feeling? What's your family history? What are the genetic elements that might be in place? Tests and scans, if appropriate, based on the physical exam. So between the healthy lifestyle, which we do not want to ignore, and the assessment of, do I have early signs of vascular disease? If so, hey, how can I be more aggressive in my treatments to prevent it from becoming bad enough that I'm at risk for a heart attack? That's how you want to address it. So the medical visit should be a good history. How are you feeling? What do you do? How active you are? A good family history. We think that a family history is high because a family member had a cardiac event. That's actually not. If it's a male member before the age of 55 and a female member before 65, that might suggest some genetic component. But if your grandfather at 82 had a heart attack, that's not going to put you at a significant risk. So what's that family history? And the doctor should help put all those pieces together. There's no one factor. It's all the things in your lifestyle and all the markers. And if it comes out, and it could be some tests that says, hey, you've got some early disease in your arteries and or you've got some increased risks. Let's talk about tools and weapons to control that so it doesn't progress to the heart attack. So I think your attention, your awareness is the first step. Lifestyle, aggressive, changes in the lifestyle, all of which can be done cheaply and safely. Don't lose sight of that. And the medical evaluation would be involving certain simple blood tests, a physical exam, other tests, depending on what those answers to those questions would look like.
Dr. Fialkow, before we go to the next question, I want to touch on something that you mentioned, which is the blood work. These tests, we've come a long way from testing of maybe what our grandparents and parents are used to. There's so much more available on the market as well. Can you just dive in quickly as to, are there more specific, more enhanced testing that can give us a better indication of our cardiac health?
So that's the exciting part of what I've been doing for 15, 20 years, if not more, and the precision approach we have in our prevention clinic, which is just that. We start with what's called population data, which was phenomenally important, started 50, 60 years ago, which are what are the trends in large populations we might see to help pick out those people at risk. But going back to the comments we made earlier, Kathy, that's a probability. So for example, if I have 10,000 smoking diabetics, I'm going to see more heart attacks and strokes over 10 years than if I had 10,000 non-smoking diabetics. But not every smoking diabetic has a heart attack. Not every non-smoking diabetic doesn't have a heart attack. So for populations, it's great. But when I'm sitting in front of a patient, that patient wants to know, what do I have? What's my risk? And that's where I think the evolution has come, both in certain imaging tests. Coronary calcium score is something that's a very important weapon we have when used correctly to assess one's risk. Certain blood tests, there's a test called LP-little-a, lipoprotein-little-a, a genetic marker, which has finally gained a lot of attention. I've been dealing with it for 12, 15 years. These are things that stratify a person further from, yeah, my cholesterol's high, my blood pressure's high. What does that mean to, wait a minute, I have this, and that might increase or decrease my probability of a heart attack. So I'd want to be more aggressive. So I think the idea is going back towards a certain imaging tests when done appropriately and more advanced blood tests than just what's my cholesterol, what's my potassium level, et cetera, which are great for big populations, but they break down at the individual level. I think that's the excitement that's really happening in the prevention space, how we can be more precise and personalized. One thing I tell patients, Kathy, is, if we had a crystal ball that said you'd be dancing at the age of 120 before you die and you wouldn't be on any medications or seeing doctors, you know what you'd do? You'd stop seeing doctors, you wouldn't take medications. We don't have that crystal ball. So we have to look based on medical science and observations and kind of critical thinking, what might identify something at higher risk. And that could work both ways, where we might take someone who looks like they're fairly well and find risks, but also has the double-edged sword that there might be people who are really low risk, but for some reason they're thought to be high risk. And then they get put on medications they may not need, or they're scared to avoid a food and they're fine because they really don't have risk. So the idea of the prevention center is that personalized approach, not how do my numbers stack up to someone else's. What do I have? What do I need to do? What would be my recommendations, and not from a piece of paper because everyone's different.
Absolutely. That key word is personalization. Okay, so this next question, Dr. Fialkow, comes from Juan. I was recently diagnosed with type 2 diabetes because he caught it early. The doctor said he can help me manage it with lifestyle changes and medications. I always try to be healthy, but now I'm kind of deflated. Is there anything else I could have done to prevent diabetes and my higher risk for cardiovascular issues? So I know many people have shared similar comments about living with type 2 diabetes. You just brought it up as well. What do you say to these newly diagnosed patients?
Yeah, so there's a great question, very common, a lot to unpack there, and hopefully I won't go down any rabbit holes. But type 2 diabetes is actually a carbohydrate intolerance. As living organisms, we require nutrition, right? Nutrition is food. There are three sources of nutrition that human beings can use: fats, proteins, and carbohydrates. All right, plants can use sunlight. We use fats, proteins, and carbohydrates. Carbohydrates trigger a hormone called insulin. And what insulin does, it takes the carbohydrates, which are sugars, they get eaten, absorbed into our blood, and we don't want them in our blood because sugar in the blood can be damaging to our organs. So we store them. We store them in our belly fat. They're supposed to go to our muscles. So the idea of insulin, get the sugar out of your blood. When we can't make enough insulin, or the insulin doesn't work, it's called insulin resistance, then the sugar goes up in your blood because we can't get it out, and that's diabetes. So diabetes, type 2 diabetes, is the result of many years of abnormalities leading to this inability for the insulin to get the carbohydrates out of your blood. What could you have done? I would pay less attention to that, but in terms of what we should be doing, it's the same type of thing. Avoid processed foods. Now, what's a common processed food? Sugar. I mean, sugar is a refined substance. It's not really part of our natural diet. It's not essential for body life. You have to eat certain fats. You have to eat proteins. You don't eat sugars. So type 2 diabetes is a carbohydrate intolerance. Now, where it gets a little screwy is this insulin problem leads to inflammation in the body. The inflammation affects all our organs. It increases dementia. It increases cardiovascular disease. It increases cancer. So the actual cardiovascular risk in a diabetic is not through the sugar. It's through the inflammation of the insulin. All right. Enough of the science. Why is this relevant? Keep your weight down. Avoid processed sugars and starches because those trigger the insulin need. Don't smoke. Get the good night's sleep. Same recommendations. So if someone is already insulin resistant, they already have type 2 diabetes, their sugar's up, the insulin can't get the sugar out of your blood, the first thing I recommend is keep the sugar out of your diet. Why take all these medications to help your body get rid of the sugar if you just don't take the sugar in? So I generally recommend really sugar avoidance. I don't think really any real processed refined sugar is good, and certain carbohydrates. Now, secondarily, yes, we will use medications to decrease that insulin response, decrease the inflammation, so you don't get that cardiovascular event. So if someone is diagnosed with type 2 diabetes, there's a lot of data now that we can actually put it into remission which means your sugar normalizes, the inflammation normalizes with various, certain diets, again, avoiding sugars and starches and some carbohydrate restrictions, and then certain medications. Weight loss becomes predominantly important as well, because that increased weight puts inflammation and stress on our body, and the inflammation leads to those components. Now, again, as someone who's been dealing with weight management for decades, it's not willpower, it's not it's not it's not a personal flaw. It's hormonal abnormalities which cause people to hold on to energy. That's why these GLP-1s, these whole families of medications, are not just showing they lose weight when you take them, but you also prevent heart attacks. You're preventing kidney failure, you're preventing all those other things. So if you're a type 2 diabetic, don't get discouraged. Exercise, that helps your body utilize the energy better, helps your insulin response. Secondly, keep the carbohydrates out of your diet, substitute protein, substitute fiber, substitute, more complex carbohydrates. Obviously, certain fats are okay in certain amounts. And then concentrate your other risk factors. And really, it should not be anything that would cause any problems down the road. Don't rely on medications. They're helpful. You'll need them if properly given. But lifestyle can really correct it.
Okay, our next question comes from Val, who emailed and asked, Doctor, I've noticed lately that I'm out of breath a lot faster these days when I exercise. Am I just out of shape, or could it be something more serious? Great question.
Yeah, that's a great question, and something that creates a lot of confusion as well. The bigger picture I would look at, and I always look at things from a 30,000 foot and then a more granular level. The bigger picture is you've noticed a change in the way you feel. And that generally is something that should warrant a medical appointment, whether it's increasing shortness of breath or gaining weight or losing weight or change in bowel habits. When someone has a certain routine and something changes, it's not always a sign of something bad, but it should warrant some evaluation. So in this case, if you say I am out of breath faster, you're saying compared to a different time. Now, also, when people exercise, they're training the large muscle groups of their body to be efficient. So you can do an activity, doesn't take as much out of you. If you're not exercising, you climb a flight of stairs, all those muscles are being used, and you're short of breath because the heart is working harder to get oxygen and blood to the body, and your lungs are working harder to get oxygen to the body. If those muscles are in shape, because you do a lot of climbing, you pop up the stairs and you don't matter. I have people that can run 4 miles a day, and they climb a flight of stairs and they're short of breath, and they come in thinking something's wrong with them, not realizing when you're walking or running, you're using different muscles than climbing. So the climbing muscles are out of shape. So sometimes when people do an activity that they haven't done in a while at an airport, running down Miami International Airport, looks like 2 miles, and they notice something, it's not always a sign of something bad. So I wouldn't worry, but if you notice that you're getting short of breath faster, it could be a sign of an early cardiac issue or a lung issue. Or you're out of shape and getting older, which also warrants an intervention, i.e. an exercise routine. So I think it's important to listen to your body. If you see any changes, consider if it's something that's unusual you can't explain, and you should discuss it with your doctor. But it doesn't mean you're guaranteed to have a cardiac condition as the cause for that complaint.
Well, anyone who's running an MIA airport knows that a 2-mile stretch feels like a marathon. So, yes, I agree with you.
Disney World and Miami International Airports are the world's greatest stress tests, as far as I'm concerned.
Really, seriously. Okay, let's keep this going. So our next question comes from Sienna, and she writes, my feet have been swollen a lot lately, and I went to the doctor who said it could be one of a few things, including something with my heart valve. How serious is that, and how does that happen?
Okay, so very common, usually not cardiac, but it can be, and that's why I think it's appropriate to get an evaluation. And this goes back towards the history. When does it happen? Do you wake up and your feet are okay, and it happens over the course of the day? Are you short of breath when you lie down? So there's no simple symptom that suggests exactly what you have. It's a constellation of things. The arteries bring blood to our feet. The veins bring them back. The artery are under a pressure, right? Your heart's pumping the blood pressure to your feet. The veins are a low pressure. If the veins can't bring the blood back to your heart, right, as part of your circulatory system, then it puts fluid into your legs, and gravity can do that. So more importantly, if at the end of the day you find your legs are a little puffy, that's probably something called venous insufficiency. The veins don't work well to bring the heart back. It's usually from gaining weight. It's usually from people who've been on their feet for long periods of time. Teachers, people who work in retail get that. And it's usually benign. It's treated with either elevating your feet, support stockings to keep the pressure on the legs, which most people in South Florida don't wear because they're ugly and hot, but they do work. When you have a cardiac condition, it means the heart can't pump the blood that's returning to the heart well, so the pressure builds up and puts pressure into your legs. It's usually associated with other symptoms. You're short of breath when you lie flat. You find you need a couple of pillows. Why? you have some extra fluid retention. It's in your legs when gravity pulls it down. When you lie down, it moves from your legs to your lungs, and you get short of breath and have to sit up. So again, part of that history can help elucidate what's going on. If it's pretty simple and the doctor can recommend, support stockings, that's fine. Sometimes you might get an ultrasound of the veins of your legs to see if it's something more serious that can be treated. And then if there's other concerns that it could be from a cardiac symptom, usually it's an echocardiogram, a simple ultrasound of your heart that can look for the pressures and signs. Going back to your point, a valve problem can put pressure on the heart because the heart's pushing blood forward, and if the valve doesn't open well, then the pressure builds up behind the valve, or if the valve leaks, then blood's coming backwards. So valve problems can cause swelling in the ankles, but usually associated with other symptoms, difficulty breathing, can't lie flat in bed and whatnot, and certain things on the physical exam. So it's part of the differential, but most commonly a little swelling in the ankles, and people otherwise feel well. It's the veins not working well with age and gaining weight and various other components.
Okay, next we hear from Albert, Dr. Fialkow, and he wants to know, I'm 60 years old and I'm having some trouble breathing. I know I need to get checked out. What can I expect as far as diagnostic testing when I go to the doctor? And we talked a little bit about this, how testing has changed over the years. And this is a 60-year-old man. So what would it look like?
So again, it goes back towards a good history. Is the breathing when you're exerting yourself, or is it when you're sitting in front of the TV resting? Does it last for minutes, or you're gasping for air? Sometimes people just sit there and they just notice they're taking deep breaths. So the timing, when it occurs, how persistent it is, does it limit you, how much it's changed, this gives us insights as what it could be. If it's going to be a cardiac issue, it's usually with exertion, right? It's not when you rest. So if you're sitting there watching TV and you feel short of breath, but then you can go, walking to the mailbox or climb stairs, it's generally not a cardiac condition, because most cardiac conditions occur with activity as their first symptoms. It could be a lung issue. Do you smoke? Do you have, asthma? There's many other components with it. So if you're going to a doctor saying, I'm having breathing problems, the history, the questions that should be asked should define what pathway to take. From a cardiac standpoint, we would generally look for, is it a heart, muscle, and valve problem? In which case, an echocardiogram, an ultrasound, we bounce sound waves off the chest to take pictures of the heart, no radiation, totally safe, fairly fast. And depending on the components, we would either do a stress test where we walk you on a treadmill and we see if we reproduce the symptoms and if there's any cardiac issues showing up with that, or another scan called a CTA, a coronary CT, which can look at the arteries. So again, those are the general tests we do in the cardiac situation. Lung scan, they might have you breathe through a tube and do a spirometry to see if the airways are narrowed. X-ray can help to make sure that there's no issues with the lungs. So again, the point is get checked out, but what the workup would be should very much depend on how it's presenting for you and what it's associated with and what your other lifestyle and or medical conditions are.
Thank you, Dr. Fialkow. Okay, we have another question from Charlie. I'm a high school basketball coach and recently overheard my players joke around about vaping. They listen to me when it comes to playing, but I'm not sure how to get the message through about it, how dangerous vaping is. Any advice on how to have this conversation? What does it do to the body, Dr. Fialkow?
Yeah, so, when people smoke cigarettes, as obviously the biggest culprit, you're burning a tobacco product and inhaling the smoke. With vaping, you're actually heating a chemical and inhaling the vapor from the chemical. So you're not burning a substance, you're heating it, but you're basically taking chemicals and bringing it into your body where they don't belong. So vaping is not safe, maybe some less risk to the mouth from the smoke contents, but the real issue with vaping products to me as a cardiovascular specialist is nicotine. Nicotine not only is the addicting substance, but also gives the pleasure. But nicotine has significant negative consequences to our cardiovascular system. It's inflammatory to our blood vessels, so it leads to the coronary disease that leads to heart attacks and strokes when it's in the heart and when it's in the vein. It can increase blood pressure. It can increase our heart rate. So nicotine is really the culprit no matter what form you take it in. Even patches and gums, it's still nicotine. As far as other components of vaping, there are some lung conditions that have been associated with vaping products if they're not pure. Some think it might be a gateway towards other components. We don't need to get into that. But going back to the messaging, I would explain to people, especially these young people who appropriately are totally into their health and into their diet. I'm like, you're taking something that does not belong in your body and you're putting it in your body. Why is it any safer if it's something you're inhaling that's been heated as opposed to something you're eating or taking otherwise? So like I said, when I go back, general product is keep things as natural as possible, keep foreign things away from your body. And that would be an example where vaping would be an example of something unnatural being entered into our body.
And Dr. Fialkow, I think we need a part 2 for this one because believe it or not, that's all the time that we have for today. So thank you so much for your time, for your incredible insight as always, and for joining us and sending in some really important questions. And like I said, just keep sending them in. I'm Kathy Buccio. We'll see you next time on Ask the Doc. No appointment needed.
Thank you for listening to the Health Channel podcast. We hope this information has been useful. However, please remember that only your doctor can advise you about what is best for you. Do not start, modify, or suspend treatment based on anything you have heard on this podcast. Please join us again soon.